This is first stage, the cystic lesion, CL for cystic lesion. You can see there are clear cyst in the liver, and if you look closely at this area, you can see three layers involved. This is a very typical of Hydatid cyst. There is a hypodense layer flanked by two hyperdense layer. This three-layer structure is very typical of Hydatid cyst, and it helps in differentiating this kind of cyst from two very common differential diagnoses. One is simple liver cyst and another is amoebic liver abscess. Simple liver cyst will have a single thin wall. Amoebic liver abscess, since is only necrotic parenchyma, it is not a true cyst, it is a necrotic parenchyma, so there will be blurring of the interface between liver and the abscess. But here you can see a clear defined margin and three layer in the wall. So this is a Hydatid cyst. This is clear fluid. This is the first stage. Now if you go into the second stage, when the proteosclerosis start forming, they collect in the cystic fluid like a sediment and at the bottom, and this is called Hydatid sand. If in ultrasound, if you change the posture, the location of sand will also change as per the gravity. This is very typical, again diagnostic of the CE stage of Hydatid cyst. Next, daughter cyst start forming, and we can see a large daughter cyst inside the bigger cyst. These daughter cysts have similar structure to the Hydatid cyst, except there is no pericyst. Daughter cysts don't have pericyst because pericyst is formed by compression of surrounding liver parenchyma. And since daughter cysts are inside this cyst, there is no liver parenchyma surrounding them, so there is no pericyst. There is endocyst, ectocyst, there is no pericyst. So these daughter cysts give rise to a spoke wheel pattern or rosette pattern, or you can also get cartwheel pattern. This is C2 stage. This is very infective stage. Now these daughter cysts, they tend to degenerate. The membranes tends to break up. So there's a free lying undulating membranes. This is called water lily sign. Like water lily waves in the freely in the water, with one end fixed to the ground, another end in the lying free in the water. So this is called water lily sign. This is a breakage of this membrane, and this is C3A stage. C3B, you start seeing some solid components, not solidification, because there is overpopulation. Overpopulation with a lot of degenerated component and debris inside the hydatid. So now the hydatid starts having a solid component also mixed with cystic area. This is C3B. There is mixed density on CT scan and mixed echogenicity on ultrasound. C4, again more solid component comes. Now you can see the cystic configuration is gone. Now it is looking more like a solid mass. So this at this stage the differential diagnosis would include a liver malignancy because of mixed density and had a lot of solid component. This is also called as cotton wool appearance. This is important because this is inactive phase. Now you cannot see daughter cyst or the infective area. So now the cyst has started degenerating. Then we can have a cyst which is calcified. A wall is calcified. These are called dead calcified cysts, are basically dead cysts. Now let's look at the various treatment modalities of Hydatid cyst. We have a medical treatment, we have a surgical treatment, and then we have a percutaneous treatment, that is intervention radiology treatment, which are usually USG guided. In the medical treatment, the drug of choice is albendazole. There is another drug of same class, mebendazole, but because of easier administration to patients and because of its increased bioavailability, albendazole is the drug of choice. Third drug, which is sometimes used in combination with these drugs, is the praziquantel. Praziquantel, although as a sole therapy, is not used for hydatid cyst frequently, but it is sometimes used in combination with these albendazole and mebendazole. In the surgical treatment, we have a radical surgery or conservative surgery. Radical surgery means either we are removing total hydatid cyst along with its pericyst, or we are doing a liver resection. Conservative surgery means we are removing a part of hydatid cyst. Complete hydatid cyst is not removed. Purpose of this conservative surgery is to the preservation of the liver parenchyma as much as possible and also decrease the morbidity, because radical surgeries leads to increased chances of bleeding, biliary fistula, and more complications. In the percutaneous treatment, which is USG guided insertion of a needle or catheter, there we have a needle aspiration, which is called pair. Then we can insert a catheter. But catheter can be narrow bore, 4 to 6 French catheter, paids, and wide bore, 14 to 16 French catheter. In the procedure in which wide bore catheter are introduced are MoCAT and PEVAC. Let's see in which stages of hydatid cyst which treatment is used. Now, if you look at this first stage, the CL, it is a clear fluid. There is no sediment, there is no thick septated areas. It is a clear fluid. Start with the medical treatment. Medical treatment given in all stages. This is to sterilize the area, to kill the protoscoleus daughter cysts. Now, since this is clear fluid, the best procedure for this would be pair. We introduce a fine needle from outside, that is percutaneous. We aspirate the fluoxetine content. We inject an scolicidal, and then when we re-aspirate. So this is a pair technique. Now, one thing is important for pair technique. One is that sometimes these cysts may have communication with the biliary radicals. The biliary radicals may actually open in these cysts. So if you are introducing any scolicidal agent, this agent may get inside the biliary radicals and then may cause cholangitis. This is one risk of introducing a scolicidal agent in the cystic fluid. So how to avoid this? We have to check for the presence of cystobiliary communication. If then cystobiliary communication is there, pair is contraindicated. So pair is contraindicated in cystobiliary communication. So how to confirm cystobiliary communication? You the one technique is that you aspirate a small amount of fluid, inject a contrast agent, and then see whether the ability is opacified. If ability is opacified, then it means there is cystobiliary communication. And second thing is that when you are aspirating, look for the color. If it is a bilious color, if it is yellowish tinge or greenish, dark yellow color tinge, then this means there is a bile present. So you don't abandon the procedure, don't do pair. If there is no cystobiliary communication, you inject a scolicidal, leave it for a few minutes, and then re-aspirate it. You may repeat the procedure. The preferred scolicidal agent is 20% hypertonic saline. Now, many times, earlier days, you will see many times people they used formalin or povidone iodine. Formalin povidone iodine is not discouraged. They should not be used because if there is a minor cystobiliary communication which is missed, they will lead to a intense cholangitis and will lead to fibrosis of biliary tree. This will lead complication. So 20% hypertonic saline is a safe scolicidal agent even if there is cystobiliary communication which is missed. Still, it will not cause an sclerosing cholangitis. So in this CL stage, best is medical treatment. Start medical treatment plus pair. If pair is not available, you have option for surgery. Now, suppose there is cyst which is very small, less than 5 centimeters small cyst. In such cases, you may go for medical treatment alone and then look whether cyst has regressed or not. If the cyst is regressing, or if there is calcification appearing in the wall, this means cyst is dying. So there's no need to do pair, just wait and watch in less than 5 centimeter cyst. In CE stage, the hydrated sand stage, you can see a hydrated sand. So it is important to remove this hydrated sand also, which is very difficult with pair. One thing is, you start with the medical treatment, you do a pair, leave hydrated sand behind, do a pair, wait for medical treatment to do this effect, and scleroside agent which you are injecting, it may also destroy the small daughter cysts or put sclerosis present in these hydrated sand. Another option is, you can put a wider bore catheter like PADS 4 to 6 French catheter, and then you can aspirate some thicker hydrated sand also. So treatment in this stage, medical plus interventional radiology, pair or PADS. If contraindicated, go for surgery. Now in this cartwheel, this is the most effective stage. You can see the daughter cyst, multiple daughter cysts. You cannot do pair of each daughter cyst. It is technically impossible because there are multiple, and multiple needle puncture will lead to more complications like bleeding. So in this cartwheel appearance C2 stage, surgery is the treatment choice, of course, along with medical treatment. As I said, medical treatment is to be given in all cases. C3 stage, again the divided cystic cavity again has collapsed into a single cavity with free lying membrane. The membranes are free lying in. So you start with the medical treatment, and now apart from aspirating cystole, you need to remove these membranes also. So instead of wider bore catheter, you can go for MoCAT or PEVAC. This is a procedure of choice, MoCAT or PEVAC, because you need to remove the membranes also. With the 14 to 16 French catheter of MoCAT and PEVAC, you can insert a fine forceps and aspirate, remove these membranes, aspirate the fluid and remove the membranes. Again, if not possible, then surgery. C3 stage, now solid portion start to come up. Where there is solid portion, the interventional radiology is not very effective, so treatment is medical plus surgical. You cannot remove the solid component through a catheter or needle, so there is no advantage doing interventional radiology. Medical treatment is started and then surgery is done. C4B stage, there is a lot of solid component, there is no role of interventional radiology, start with a medical treatment, but these stages are mostly inactive features, they are dying cyst, so you can give medical treatment alone in this case and wait for watch. If needed, you can go for surgery. Now in this CA5 stage is basically inactive stage, this is a dead cyst. So in CA5 stage, you do a watchful waiting, means you don't do anything, as cyst is probably completely dead, there are no scoliosis produced as a daughter cyst alive in there. So this often happens because of a body immune response and aging of the cyst. So you don't do anything, do a watchful waiting and wait. And these cysts are probably detected incidentally when imaging is done from some another reason. So these cysts don't create a problem, don't grow in size, and they stay silent for a long time, or maybe whole lifetime. So don't do anything C5 stage.
Join our YouTube channel to learn surgery in a simple way.